Hi, Kay Grace, physical therapist, orthopedic physician assistant, founder of Our Joint Effort. Our whole purpose here today and every day is to give you really great orthopedic medical advice. I hope some of you saw the podcast last week where Darlene, who was about to have her third ACL surgery 3 days before I met her, and thank God we met because that would have been another failed surgery for her, another year, a year and a half of rehab, and more pain, swelling, and discomfort. We got her the right diagnosis. We got her to the right doctor. We got her the right surgery. It's been 2 years now, and she can do everything she wants. And in fact, she picked up pickleball. So it was miraculous. If you haven't seen it, please go back and see. So this is our follow-up to ACL, but everything I say today can pertain to any knee problem, any other joint problem, because it's about educating you about really great care. So you're out playing a sport, or maybe you're just walking along the street, your knee gives out, or you get hit, or maybe you saw Mission Impossible and you decided to hang off an airplane like Tom Cruise or jump off a cliff, and you go down, your knee, you feel a pop, your knee is very painful, immediately swells, and you can't bear weight on it, and it's really painful. Here's what you do first. You get off your leg, you go home, and you ice. And that stands for ice, compression, and elevation. And I tell people to throw their leg on the back of the sofa, lay down, throw your leg up there, and put some ice on it and wrap it real tight with an ace band, compression on it. Because what's going to happen is the swelling is going to leave your knee up your leg into your lymph nodes, and then you're going to get rid of it. So to avoid further damage, tissue, or other structures, you want to make sure that you stay quiet, probably get on some crutches, ice it. And, these instructions I see all the time, people say, ice 20 minutes on, 20 minutes off. Hell no. Put that ice on there until your swelling's down. You can leave it on there all day long if you want. Just make sure you have some protective coating over your skin so you don't burn yourself. So ice it. Minimize the damage of your knee, get the swelling out. The swelling occurs as a protective mechanism, just like if you sprained your ankle. Why does your ankle get swollen? Because it doesn't want you to tear that ligament anymore. Same thing. So it's really a protective mechanism. Embrace that swelling, but get rid of it. Next thing, you've got to find a really good doctor who will sit down, spend time with you, do a thorough exam, and come up with a diagnosis. You may have torn your ACL. You may not. You may have torn your plica, your synovium, your cartilage. You don't know, and you don't know how to treat it until you get the right diagnosis. So you go to somebody really good, find out what it is, and then you can go from there to treatment. Do you need an MRI? Maybe, maybe not. MRIs are so many false positives and negatives. They're not perfect. So we never make a decision on what to do with a patient by what their MRI says. The physical exam, the history is really important. And by the way, whether it's moms and dads and their kid goes down on the soccer field, or it's you, there is no rush. One of the worst things I've seen in my practice is somebody is out skiing, they tear their ACL on the slopes, they go down to the bottom of the slopes, they get into the emergency room or go to one of the local ski resort doctors and they say, oh, you tore your ACL, we're going to operate today or tomorrow. No. We start with physical therapy because you have to get all the swelling out of the joint and you have to get your range of motion back before you have surgery. Otherwise, first of all, when we stick the scope in your knee, you can't see anything because it's full of blood. So that's dangerous. Secondly, a lot of people who have surgery when their knee is in an optimal shape, they end up with a stiff and painful knee after surgery, which should not happen. So don't rush, get good advice, and always start with physical therapy. So when we see you in PT, you're going to come in, we're going to get that leg up in the air, we're going to get the swelling out of your knee, and we're going to get your range of motion back. And then we're going to start strengthening. So maybe you tore something else. Maybe you have a partial ACL tear, and maybe you can get away with doing physical therapy without having surgery, but you will never know unless you do that. So always start with therapy, and we'll describe what really great therapy is. But let's say you've done that, maybe a month, maybe 2 months, and you go back to whatever activity. Maybe you're a golfer or a kayaker, and go, you know what? I did have this knee injury, but I can go back and do those activities that I love. Great. No surgery. You're going to go back. You're going to be fine. So you maybe tore your ACL, partial ACL, maybe you tore something else, but your therapy has resolved that for you and you're back to doing the activities you love. Let's say you did all that and it wasn't successful. And you do go to the doctor, they do several tests, they do an MRI, and they see that you had a complete ACL tear. So what is that? Anatomically, here's my man, Seymour. This is what your knee actually looks like. This is the front, your patella, housed in this tendon, femur bone, the big one on top, tibia on the bottom, tibia on the side. Your ACL and PCL are deep in the joint in here. There's your PCL. If I remove the patella, there's your ACL in the front. You can probably tell that they're crossed. That's why they're called cruciate ligaments. The reason for the anatomical position of them attached to the tibia and the femur is it stops this motion from occurring, this shift. And if you lose your ACL, patients will actually describe that as my knee, I'm walking along and my knee shifts or it pivots. It does, because it doesn't have the stability in here. We check everything, the MCL, LCL, and your meniscus that are in here. All these tissues can be damaged with an injury. So let's say that it's 1/3 torn. You can probably get away with PT, strengthen all the secondary restraints. Complete tear, needs surgery. It's that 2/3 tear that it's kind of we don't know. And what you want to do, make sure with that is that you complete really good therapy and you make sure that you give it the best possible opportunity to strengthen. And if you still are unstable, then you can talk about surgery. So for that 2/3 tear, though, there is some new research and data out on injecting PRP and stem cells into the ACL. It's a little early. If you're interested, there are some studies going on right now, some clinical trials. So you might want to look into that. It's early for that. It's not early for stem cells and PRP, as you probably saw a few weeks ago, but it's early in the ACL. So promising. So maybe that'll help people with a partial tear. So you have a complete tear and we're going to go, okay. And this is just like you're sitting in the office with me, how I would advise you. You have got to pick a great surgeon. And that surgeon is someone who will sit down with you, do a great exam, diagnose your knee properly, and talk to you about all the options. So to do an ACL reconstruction, you can use several things. They all have pros and cons. You can use an allograft, and that means it comes from a cadaver. The good news about that is you can say, maybe it's a great big football player and you need a big stout graft. Maybe it's a small dancer. You might not need such a big graft. You can literally request, I want this long of a graft and this big in diameter. The other thing would be an autograft, and that comes from you. So it can be bone patella bone, taking out a piece of this patella tendon, or it can be a combination of a couple of your hamstring tendons from the back. That's an autograft. So what is he going to recommend, or she? Well, probably something that they're very familiar doing with and they feel most comfortable doing. Nothing wrong with that, but is it the best graft for you? So what I recommend to everybody is do your research, make sure you get 2 to 3 opinions, and you are going to, by that time, you're going to know a lot more about what those reconstructions involve. And you're going to get a sense that this doctor is going to take really good care of me, whether the results are good, bad, or different. He or she are going to take good care of me, and they have sound thinking of how they're doing their surgery. The other thing I will recommend is please ask them how early they start physical therapy, because it doesn't happen so much today, but in some areas where their medical care isn't the greatest or there's a big population, they'll say, well, we're going to put you in a brace for about 6 weeks. No. Go turn around, say thank you very much, and get out of there. You will end up with a very stiff knee. We start therapy around 5 days post-op. And that's really for your comfort, because you're not going to have the pain from the incident or the injury anymore. You're going to have post-surgical pain. And a lot of that pain comes from swelling. So what's great physical therapy? You come in and see me. I do it, take a good history, great exam, look at your knee, and figure out a treatment plan to get you, progress you as quickly as possible. I'm going to get you up on the table with your leg elevated to help let gravity help drain that fluid out. We're going to push all that fluid. We're going to do some deep tissue work, push all that fluid out of your knee, and we're going to start working on your range of motion. And then we're going to start doing gentle muscle contractions. I'm going to give you things to do at home to maximize the benefits of PT, but that's going to be what it's like for about 6 weeks. I'm going to probably want you on crutches. I would think you'd be on crutches because I don't want you to limp and I don't want you to weight bear on that knee just yet. So as those 6 weeks go by, we're going to progress your gait to make sure your gait is as good as it could possibly be. Then at that 6 week mark, you're going to have to start working harder. So we are going to progress all your exercises, increase those weight bearing exercises. And really good therapy is your therapist, your physical therapist gets their hands on you. Your physical therapist does your exercises with you to make sure that you're doing them right and they're functional. Your physical therapist progresses you from treatment to treatment to treatment. So this week, you could barely step up on a 1-inch step, but then you mastered that. The next week, maybe it's 2 or 3 inches. So every week, or even more frequently, it progresses. You are not shoved off to an aide. You're not shoved off to somebody else and say, oh, go over there and do those exercises. That is not physical therapy. If that's what you're currently getting for any of your joints, spending 5 minutes with the therapist and then shoved off to somebody else, contact me. I'll find somebody good in your area because that is not physical therapy and that's not what you need. And that's not what not should happen. I'm a little passionate about that, but that is not what should happen. So now we're in that 3-month area after we've increased your strengthening. And by the way, it's not just your knee we're strengthening. We're strengthening you from head to toe because your hip and pelvis affects what goes on in your knee. Your ankle and your foot affects what goes on in your knee. Even if you have a forward head or you're rounded in your mid back, or maybe your pelvis is in an abnormal position, that affects your knee. So a good therapist will treat you from head to toe. Then about somewhere in 3 to 6 months, depending on where you are. And also, I get asked this a lot. How, Sally over here and Mary had the same ACL surgery, but Mary's way ahead of Sally in therapy. And how come Sally's not, wimp? She's doing her stuff. It's because after we do a surgery, it's our obligation to also look at the rest of the joint. What else is going on in the joint? Did you damage anything else? What's the status of your cartilage? Do you have worn down cartilage? Do you have arthritis in your knee? If you have something other than just a pure ACL tear, then it is going to take you longer to recuperate and to go through therapy because there's other structures involved that have to heal and get back in the correct anatomical position. So when I see someone, I do look at their MRIs, I do look at their x-rays, and I also read their op report because I want to see what the condition of your knee is or your shoulder or your back during surgery when they got a chance to look in there. It gives us a really good look. And that was one of the best things about being a PA in surgery was I got to see inside the joint. And it really helped us explain and describe to you why maybe you're not progressing quick enough. There's always a reason, unless you're sitting on your couch eating Cheetos and not doing any exercises, but we don't usually allow that to happen. So now we're getting to the fun part. We're getting to the part where we're doing sports-specific training. And whether it's basketball or baseball or tennis or pickleball or volleyball, we are training you for that sport. And we do not let you go until you have passed a sports-specific test. There is a return to sport test for every joint, shoulders, elbows, knees, hips, that we test to make sure you're ready to go back, because the last thing you want to do is re-tear that. Because when you go in and do another surgery, its outcome's not going to be quite as good. The ACL graft, as good as surgery is, it's not going to be as stable as the one you were born with, because we're taking an abnormal substance outside your body, sliding it through that same tunnel, and we're putting screws on either end instead of the ligament being attached directly to the bone. So it's not going to be quite as good. And the revisions really aren't good. I mean, poor Jerlene, she had a revision already, and she realized how they don't work so well. So we test you, we do a return to sport test. If you're ready, then we go, you're good to go. The last thing you want to do, let's say you're a soccer player, you have to run forward, backward, side, lateral, stop, start. You want to test that on the field? I don't think so. Worst place to test it. So we will test you and check off and say, you're good to go. The injury rates, it kind of depends on ages, what the rest of your physique and strength is like, but the re-tear rate can be anywhere from 50 to 20%. And most of those people who re-tear or re-injure their ACL do not return to their sport. So be better to be safe than sorry. Who cares if you miss, a season when you're a sophomore? It's more important that you perform when you're a junior or a senior getting ready for college. So return, that is just so important. I hate when I see that, and I have seen that in my practice, because it is avoidable. So don't let that happen to you. That is a very quick down and dirty on the ACL and knee injuries. And before we get into our AKA Ask Kate Anything, and by the way, you can ask me anything about your orthopedic problem. It doesn't have to be the knee. Next week, we are going to change up our schedule and talk about peptides. And the reason is everyone's talking about them. I get calls or emails or texts. Hey, why don't I just do peptides instead of stem cells? Well, apple, orange. It's not anywhere near the same thing. Or how about if I take these peptides? Well, let me look at it. These are vitamins. So it's not the amino acid. It's not what PRP and stem cells treat, something very different. So I'm going to clear up the whole peptide mystery and give you some information so you choose the right treatment for whatever your challenge is. So that'll be next week. I'll look forward to that. And that I know we'll get a lot of questions about, because I get them on a weekly basis, if not more frequently. So there's your ACL top to bottom, injury to surgery. I want to open it up now to Ask Kate Anything, and my illustrious producer back there is going to let me know if we have any questions about the knee or anything else.
We have a question. My child's coach keeps pushing her back to get to practice. What can I say to him to let him know she is not ready?
Question is, my coach keeps pushing my child to return to practice. And what do I say to him to tell him she's not ready? I've had many a fight in my career with coaches. God love coaches. They're fabulous, but they need to listen to the medical people as well. I had a girl who, I think she was 12 or 13 at the time, she came to see me. I won't name names, but she did live in Mexico. They did have a house in the Coronado Cays. And I do think she was going to be the best tennis player in the world. This kid was she was like a little Serena. And every part of her game was fantastic. Well, she got plantar fasciitis in one foot. Somebody sent her to me. I treated her. I said, you have got to stop playing for at least a couple of weeks, and then we'll go from there. Treated her, started where she was a little bit weak in her core. She wasn't doing a lot of cross training. So my goal was that when she got done with me, she was better than she was before. So her coach kept saying, she's got to play in this tournament. She's got to play in tournament. She's 13. I mean, she has a lot of tournaments she's going to play in. So he brought her back too soon against my judgment. She ended up getting plantar fasciitis in both feet. And she came back to me worse than ever. And then I said, all right, you are taking 3 months off. And I thought his head was going to blow off. I said, you want her to be a long-term professional tennis player? You've got to stop now and let us heal this. Even her foot mechanics were horrible. Her hips were weak. I mean, there were so many things that we could have done in that 3 months to get her really, really strong and so much better than before. So he let her rest for a month, and she just now went on to, I think she might have turned 14 or whatever. Um, she went back too soon at his insistence. Her feet were feeling better, but not completely done. The fascia was not at the length where I wanted it. Her foot mechanics were not where I wanted them. And she went back, got worse, worse than ever. She actually came back in and started crying in my office and said, "Kate, I can't stand it, but I don't know what to do. My parents, say, listen to your coach." Um, and I'm sure he was a really good coach. But what happened was then she started getting discouraged about playing tennis because it was so painful, and she didn't see the light at the end of the tunnel. She didn't see that a short-term time off and the right treatment could get rid of it and have her be better than ever. The other thing that happened about that time was she got interested in boys. And she was a little more interested in going to school and the parties after and that kind of stuff. So she actually stopped playing tennis, and it was a crime. I'll never forget her or her family. And I just wish that she would have taken my advice, and the coach would have taken my advice and not pushed her. And I think you would have watched her play tennis today. So thanks for that question. I'm not sure who that was, but it's a great question. I ran into that a lot in my practice.
Bobsy would like to know, do you recommend wearing a brace when returning to activity?
Do you recommend a brace for returning activity? I think that's a great question for two reasons, and I'm glad you asked that. One, there is no great brace that will stop that pivot or shift, but there are braces that will hold your knee in a little bit tighter, and I think that they're useful, yes, but I think they're most useful mentally. I think that the athlete feels better in a brace. I think that they feel like they're protecting their knee. And I'm glad you asked this for that reason too, because I had a lot of kids I treated that weren't mentally ready to go back. They had a really hard time with confidence. And you got to get back on that field, particularly if it's a fast moving sport, that you're confident that you can run up and down that field and know your knee's going to respond, and that slip or that pop or that injury is not going to happen again because they remember what that feels like. It's not pleasant. So that's why the return to sport test is very important. I think the other thing I ran across a lot was that the kids, they missed being with their buddies. They missed being with their teammates. They missed the camaraderie. And I think they missed the endorphin they felt when they did perform their sport and they ran a lot and they got their cardiovascular up high. And it was kind of pretty much a letdown. So I've done a lot of psychological counseling with these kids and to make sure that they were ready physically and mentally. And that, back to that brace, I think it helped them with their confidence. But for kids, especially parents, you got to help these kids and understand all the parts that go along with this injury. It's not just one little ligament in a knee, it's a big picture. So thanks. That was a great question. I'm glad we got to talk about the mental and psychological part, because it plays a big role.
We also would like to know the biggest reason for non-impact tears.
Reason for non-impact tears. I don't know. I'm not sure anybody knows. I had a guy one time went up for a layup in basketball, nobody around him, and he tore it. He didn't have any contact with another player. I'm sure it was on the way down. But what happens is that when your foot hits the ground in an abnormal fashion and your knee goes in, which you commonly call knock knee, or it's knee valgus. When your knee goes in, your rest of your knee pivots the other way, and that can tear it. So just landing wrong or some non-contact can. I don't know the numbers on the non-contact versus contact, but it can happen. And it's just you get your knee in the wrong position. Your knee's not a big stout joint like your hip, and it doesn't have all that great muscular support or that deep ball and socket joints. You got to be careful of how you use your knee. It's built as a hinge joint, so it's built for mobility. And so you got to be careful how you use it.
And then do people who have knee replacements still have ACLs or PCLs? And do they also have kneecaps after having knees replaced?
After knee replacement, is there an ACL, a PCL, and do they still have a kneecap? Yeah. Other good question. We have to remove the ACL to get the components in for the total knee, the femur and the tibia. But that's okay because that joint's very solid. Most of the time you can do what's called a PCL sparing. I think most surgeons today do that, where you keep the PCL. So you've got that one cruciate in there to hold that together. What we do for the patella is we remount the back side of the patella and put a little plastic, if you will, button on the back, and then replace the tendon in the patella back where it's supposed to be. So you've got the two titanium pieces on your femur, one on your femur, one on your tibia, one up here, one down there. You've got a spacer in between. You have to lose your meniscus too. Spacer in between of this plastic, and then the plastic piece on here. So it's the plastic gets to glide nice and smoothly on the titanium. And so that's why when you get rid of all that arthritis in your knee, you've got those nice smooth surfaces. So done well, your knee should last your lifetime depending on when you've had it done.
And then Sonny would like to know, why do ACL injuries happen to females more than males?
Yeah, it's a good question. Why more ACLs in females and males? And it's also why you get more patellofemoral. It's a big word, I know. I'm going to talk about that in a few weeks in women, because women, as they grow, girls, as they grow, their pelvis gets wider for childbearing purposes, which forces more of what's called a valgus angle of the femur. So your knees go in, then your kneecaps go out, and your tibias go the other direction. So women tend to have less of a great leg alignment than boys because they have a narrower pelvis and narrow hips. Also, the other factor is that we see this happening a lot in teenage girls, and there have been a lot of studies that measured muscle strength in teenage girls and teenage boys, which does help hold everything in the knee where it's supposed to be. Plus, I say this all the time in my class, your muscles are only as good as your joints are only as good as the muscles that support them. So when you do anything, you want the muscles to take the pounding and the stress of that activity and not the joint. Well, girls in those early teen years and teenage years are not as muscularly strong as boys during that same time period. So they might not have the capacity for those muscles to contract with an activity or a load or a quick stop and start. So their knee is under a little bit more susceptible to that. But then girls surpass boys on all levels after that. Teenage years, I'm certain.
How important is balance strength between the quad and the hamstring for knee stability?
How important is the balance between quad and hamstring? Very. Great question. Because the ACL stops this shift from happening, the primary muscle that is one of our secondary substitution muscles that we want to work on to strengthen the knee without an ACL are your hamstrings. Because the more stronger your hamstrings are, it's not going to allow this shift to happen. However, quads on the front are the most important muscle to protect your knee on the anterior side. So from patellofemoral problems or other problems in the knee where you don't have great alignment or you don't have great stability. I've rarely run into people that have a huge disparity between the two, except for maybe skaters, some cyclists where they're quad dominant and they should work on their hamstring. But it's like anything else. You need to be in balance. And speaking of balance, you also need to work on your balance. So a lot of single leg activity we do with these kids, single leg activities to get their balance great, because even if they get caught in an abnormal position, they can right themselves because they've worked on their balance. Just like as an older adult, if you step into a hole somewhere, if you've worked on your balance, you can right yourself instead of fall and break something. Friends don't let friends fall and break things and go to the hospital.
And why is my knee still stiff or painful months after surgery?
Why is my knee stiff and painful months after surgery? Well, I've seen this happen, and I've seen two reasons. One, they did surgery too soon before your swelling and you got your swelling down and your range of motion back. Two, your physical therapy sucked. I'm sorry, but it just, I hated getting that patient that had surgery, went somewhere that did the little 5 minutes with the patient and then went off and had them do this or that, the other thing. They had terrible therapy. And then they come see me 3 months later and like, fix me now. My knee's stiff. I don't have my range of motion. I still have pain. About 80% of the fix of this very problem post-op is your therapy. You have got to find, again, let me help you find somebody great in your area, because it just drives me nuts. And there are good people around the country because I've done so much telehealth. I've managed to gather a great group of people in this country and beyond that can help. But it's mostly, and that, whoever asked the total knee question, most of the time when people say, well, I didn't have a great outcome with my total knee, I never got all my range of motion back, it's because you didn't have good therapy. We never had a patient not get their motion back after surgery. It's because we got our hands on them and we mobilized the joints, the patella, the tibia, the femur, lengthened everything out and got your knee to return to a normal anatomical position and not under abnormal stress. Good questions. Take one more.
Sure.
Let's take one more. I know your attention span is about a half hour and we're about there. But we'll just take one more. And if you guys have more questions, just put them in the comments after the podcast on YouTube, and I will definitely answer them for you. And if I get a lot of the same question, I'll answer them on our podcast next week, so more people have the benefit of hearing it.
How do I know if my ACL is actually torn? Do I need an MRI? Lisa.
Yeah, Lisa, maybe you jumped on late. How do I know I tore my ACL? And do I need an MRI? Great exam, number one, to determine if your ACL is torn. And you can do a MRI to confirm or deny, but that should not be the deciding factor. The deciding factor is your mobility. Are you still shifting? Are you still pivoting? Are you still unstable? Do you still have knee pain? Do you still have swelling? Those are all indicators that something is still wrong internally, of internal derangement in your knee, and we need to fix it. But given all this information in the right hands, do not worry. Don't rush. We can fix it. It just needs to be the right treatment, diagnosis, and the right procedure for you. I'm going to end right there because I know you're probably off doing something else. I will see a lot of you tomorrow in our 50 Shades of Grace workout class. So if you have any other questions, you can ask me then, or you can discuss it. And as always, I welcome your comments and, of course, your likes and subscribes, and tell me what you want to learn about. That's the whole purpose of this. Do you want to learn about shoulder problems, elbow problems? We're going to cover everything from your head down to your toe, but tell me what you want to hear about and I'll cover it for you. Thanks so much for tuning in. I look forward to seeing you next time.